Amazing morning. I really want to start with a vote of gratitude to the American Board of Internal Medicine Foundation for taking on this topic last year and continuing the discussion this year. This is a sign of leadership that you recognize that things like trust that are so complex aren't a one and done issue. They require ongoing, sustained developmental pressure in order for us to achieve our goals. And I also want to be grateful for the students and the residents and the colleagues who put so much effort into creating wonderful stories for us. I always stand in awe in this group because there are so many leaders of academic medicine and medicine in general here, and I come to these meetings and I just feel like it's drinking from a fire hose, a really wonderful fire hose that's shaped the way I look at the world of medicine and medical education. And I've learned so much from all of you. I just want to share a couple of observations, and one is I want to start with a leadership model that I think is really relevant to the work that's being done by the American Board of Internal Medicine Foundation and all of the people in this room, and this is the MIT 4 Capabilities Model. And the MIT 4 Capabilities Model says that there are 4 essential responsibilities of a leader. Relating to the people that they work with, relating to the stakeholders that they have, relating and forming relationships that are useful in achieving the goals of their organization, visioning, creating an idea of a better world that we might move towards. Some people have called that the utopian aspect of leadership. Innovating, changing the systems so that we can get to that better world, and then sense-making. And sense-making is actually creating out of chaos an understanding of what is happening today and where we might go. And of all of these capabilities, sense-making is the one that has the strongest correlation with the most effective leaders. And it makes sense to me because you think about relating without sense-making is friendship, important, but it's not leadership. Visioning without sense-making is fantasy. If you can't create a vision that can't be achieved. Innovating without sense-making is folly. But the leader who engages in sense-making has the ability to observe the ecosystem in which they exist and in which their organization exists in all of its chaos and disorder and disruption. And from a vantage point of information and insight, connect the dots to create both a recognizable picture of where we are today and a realistic map and compelling vision of the future. Sense-making and mapping actually go together really nicely because sense-making, like cartography, creates a map of where we are and where we might want to go. And in doing so, moves people from a state of general anxiety about what's happening to kind of a call to action and a sense of an ability to accomplish what you might think needs to be accomplished. So it moves people from anxiety and despair to hope and optimism. Now, there are 3 steps in sense-making that I think the American Board of Internal Medicine has started us on in a way that has been incredibly powerful for us. First, exploring the world, studying, talking, and listening. And over the past year, going on a trust tour, finding these students and residents with compelling stories and convincing editors to disseminate them through the peer-reviewed experience. Bringing together people who have trust conversations that we just heard so deeply about. That's actually exploring the world. And then actually inviting one terrific sense maker to speak to us this morning, Toyin, what an amazing talk, really, whose exploration of her world and of the many different stakeholders that she's interacted with led to her description of shocking things and lazy proxies, I think phrases that will resonate with us as we embark on this world. And she's already engaged in the second stage of sense-making, and that is creating a map of the future that you want to see. And her work in her startup company is really exciting and elegant, and she gave us 3 important steps along her map for us to follow. The first was dismantle power inequities. The second is to engineer relationships amongst all who are working in this environment. And the third was to align incentives and measures with the values that we place in trust. She's already started on the 3rd step of sense-making after exploring the world, creating the map, The third step is embark on the journey and expect to change. Embark on the journey following the map that you think is good enough to get you started, but then be aware that as the environment changes, and as you change the environment, and as you listen to more people along your journey, you may actually have to change and pivot and move in different directions. So you have to be aware of that and continue this iterative cycle of exploration, mapping, and journeying. But I'm very hopeful that she's going to get someplace important and that we're going to learn a lot as we watch her journey. So how do I make sense of today's insights from students, residents, colleagues, and mentors as you helped me explore this world a little bit more? I want to propose another way of thinking about this challenge in front of us, the challenge of trust, distrust, and trustworthiness that's in front of us. Now, when I return to UCSF on Tuesday afternoon, I have to get ready to welcome the new class of medical students who on Wednesday will start on a 3-day exploration of bias, racism, and structural inequalities as their introduction to medical school. And historically, I have introduced this, what we call the Differences Matters orientation, by talking about my experience as a resident at UCSF in the 80s, when I arrived in 82, a extraordinarily naive young medical school graduate, to find myself in the midst of an epidemic that we later knew was the HIV epidemic. And I talked to them about how this really changed the way I thought about my role as a physician. And one of the things I talked about was how powerful it was to see the medical and other healthcare professions come together and work with patients and their communities to address what was universally, at that time, a fatal epidemic. And to do so in a way that actually empowered patients and empowered communities to join us in finding a solution to this really horrific epidemic. And I talked about how not everyone was on board with that, but there were enough of us on board with that, and enough of us who are willing to learn from those who are actually at the forefront of this epidemic, patients who, as Toyin reminded us, are experts in their own life and who needed to be at the table with this conversation, that HIV now has moved from universally fatal to a chronic disease. And hopefully, we may get to zero transmission and we actually may get to a cure at some time. And I challenge them to think about what the epidemic is going to be that they need to face in their own career. And I also challenge them to recognize that epidemics don't often come in a noisy way. They're not recognized. Not everyone has exotic symptoms, and not everyone gets an above-the-fold article in the New York Times that says, look, there's Ebola or SARS or MERS. Not to say those aren't important epidemics, but some of the most challenging epidemics are the silent ones. And I would argue that the situation we have now with distrust is a silent epidemic of distrust. And I think the epidemic metaphor is fitting because of the amount of morbidity and mortality associated with this. And the problem we will have is that the morbidity and mortality is different based on who's impacted by this. So let me just talk about what I heard today and see if I can convince you that thinking about distrust as an epidemic might help us mobilize our colleagues to important work that they will join us with willingly and with a sense of purpose and a gratitude for being able to be involved in something bigger than themselves. Lack of trust is at the root of healthcare disparities. Physicians who do not trust that the patient is the expert in their own health, who do not listen to women laboring, women of color laboring in the institutions across the country, and thus lead to a higher level of maternal morbidity and mortality in communities of color. And lack of trust in communities who have been historically marginalized is the root of the suicide attempts for that poor transgendered individual we heard about in the last section. Lack of trust is at the root of low-value care, as described by Toyin in her memorable story of a woman whose chief concern was not her chief complaint. Her chief concern was her breast cancer. Her chief complaint was something that felt safer for her to talk about. Lack of trust in students is a barrier to optimal learning environments, as Andrew talked about when he had an interaction with an OBGYN who would not let him do something important to his learning because he didn't trust them. Lack of trust in educators creates a cognitive burden in students of color, as described by Mercy, who had to worry about how she needed to appear to make sure that she didn't threaten a residency program director who was evaluating her for a position. And lack of trust is also at the root of physician burnout and resident cynicism and medical student moral distrust. Because trust does not only have instrumental value in terms of improving quality of care, optimizing engagement, increasing adherence, but it has intrinsic value to us because trusting relationships are rejuvenating relationships, and distrustful relationships are damaging. Without trust, there is no meaning, and without meaning, there is no mission, and there is no medicine. Fortunately, we heard many ideas about steps we can take to combat this epidemic. And like the HIV epidemic, I'm going to argue that there is no one single magic bullet. And I think we've heard that today. It is going to be the collective actions of 1,000 people on the front lines and doing grassroots work, but it also is going to require the wise and strategic investments of big organizations like the ABIM Foundation, and our colleagues in government and at the state and local level to change. The first I would argue is that listening to people today, it really was clear to me that we need to adopt trustworthiness as our North Star. Trustworthiness may be elusive. I think Toyin talked a little bit about that, but it's actually much more concrete in the eyes of our patients than our abstract concepts like professionalism or altruism or things like that. People know whether they trust someone. And people will resonate with a message of trustworthiness. And we have to not only take that as our North Star, but we have to be serious about it, as Toyin said. We have to invest in this. We can't make these pilot efforts like the old quality improvement projects that started when someone had a grant and stopped when that person left the institution. This has to be a movement, and this has to be where all of our work is united. Because we have to re-engineer our systems of clinical care, education, and research to ensure and guarantee that people have trustworthy relationships in all of their vectors and all of their relationships. Second, we have to name and own the challenge of creating trustworthy systems and a trustworthy workforce. Again, that's part of our North Star. It's really interesting when you look at journalists have been, I think, many of the people who have galvanized us around these trust issues. When we hear on a daily basis about the lack of trust people have in their government and their elected officials, in the medical profession as evidenced by the vaccine issues, when they talk about maternal mortality and the disparities that are seen in communities of color, they raise the flag for us. And we have been strangely silent about this. There has been no medical organization that stepped up and sort of said, you know what, we will not allow healthcare disparities to exist in another generation. We are going to fix this now. This is our responsibility to work with our communities to do this. We haven't been that vocal about it. And so it shouldn't surprise us that trustworthiness is not necessarily at an all-time high in all of our communities. And then third, we have to recognize, and this may be, I put this last, not because it's least important, but because it's most important. We have to recognize that we'll never be trustworthy to our patients unless we trust them. We have to actually remember that trust is a bi-directional phenomena. We cannot demand trust, we have to earn it. We cannot expect it, we have to build it. And we can only earn it and build it by being able to be reciprocal in our disclosures to our patients, to trust them with our own vulnerabilities, whether that's uncertainty about what's right for them at the moment, whether it's discomfort at whether we actually know enough about their condition to take care of them on our own, or whether we are just actually on a particular day not really at our best. So I think that we have to, from the very beginning of medical education, throughout all of our educational trajectories, UME, graduate medical education, and CME, make trust a focus of our continuing efforts at educating and optimizing the competencies of our entire workforce. And we can't just start with our current students and residents. They're already halfway to the journey on their own. We actually have to make sure we meet them in the middle and then walk together to the future that we want to see. So I'm just going to stop there. I've been incredibly impressed by what I've heard today and incredibly impressed by the work that the foundation has undertaken. And I'm very grateful to have been allowed to participate in this conversation. And I hope that the rest of the meeting will allow us to draw that map that's going to take us into the future. Thank you.